Today I'm going to present some very recent research we've been doing in my group. I usually present research in childhood, environmental effect on childhood health from the Helix cohort, but today will be different. Today I'm going to focus most on maternal health. And I'll start by focusing on the biological question. It's a very important time during pregnancy to study the steroid hormone change. During pregnancy, we have a huge shift in the production of mainly estrogen and progesterone by up to 1,000-fold increase in the third trimester compared to the beginning of the pregnancy. And these hormones have a strong influence on the growth of the baby, but also modulating the maternal brain health. And these steroids are essential for fetal development, for birthing, for maternal neurobiological adaptation. This is a dynamic change and longitudinal, and it also helps to regulate postpartum the relationship between the mother and the child. There are different pathways involved. Normally, when we look at steroid hormones, they are measured in blood. We measure few of them, testosterone, progesterone, but actually hundreds of steroid hormone metabolites that may have slightly different health effects. Some are active, some are inactive when we measure in blood. And there's been recent studies, actually in Barcelona, where they measured very precisely these hormone changes in women. And they looked at also brain changes during pregnancy and postpartum. I thought in this conference I had to present some brain images, so here we go. And in this study, they looked at same-sex parents, so women parents, and they looked at the brain changes throughout pregnancy and postpartum in both women, the one that was gestating and the non-gestating women. And that's very useful because then you can disentangle effect of pregnancy on like life changes and more biological changes. And they found that there is a global 5% decrease in the global volume of the gray matter, and there is a partial rebound in postpartum. So that's just to show there is a huge brain remodeling during pregnancy, so potentially a sensitive period to environment. And this steroid exposure, it's also associated with the developing brain. Well, that's what we know from animal studies, but there is very little evidence in human. And these are very interesting potential markers of early environmental insults on the brain development of the child. We know that some steroids are neuroactive, such as alloprogesterone, and there's been some studies relating it to autism. So the same steroid milieu shapes both the maternal brain and the fetal brain. So I'm going to present 4 studies. The first part is going to focus on the steroid metabolic milieu question. First, what are the determinants of these hormones in pregnancy? And are they associated with the child brain development, which was our initial question when we wrote the project. Then we're going to also look at, in part 2, how some of the environmental exposure and hormones can be associated with the maternal brain health. For this first part, we focused on 2 cohorts in Spain. And the first objective was to evaluate this maternal steroid milieu during pregnancy and its effect on the child brain development and the main determinants. And these are very interesting biomarkers. They basically, the metabolite we measure in the maternal urine and blood result from a complex interaction between the mother, between the placenta, which is the main organ producing this hormone during pregnancy, and the fetus. The fetus adrenal gland actually is producing some of these androgens that then have influence on the mother. So it's a very nice metabolic pathway to study this interaction between these 3 important actors. And we want, in this project, to move beyond single steroid measurements. So we wanted a comprehensive characterization of this metabolic pathway, looking also at phase 1 and phase 2 metabolism of these hormones, so conjugated metabolites that inform on the clearance of these metabolites, but also potentially look at more active metabolites or inactive metabolites. So in the first study done by my postdoc Emily, we looked at the main determinants of these hormone profiles in 2 different cohorts. In the BISC cohort, that's based in Barcelona, we had samples for 720 women. And that's the best well-characterized cohort because it's the recent cohort. The women were recruited during COVID, before and after. So we could use novel technology, new ways to collect urine samples with repeated sampling. As we've seen, it's important for changing short life chemicals. And we did a replication analysis in an older cohort where there were slightly less information and different types of sampling, but still could help validate some of the determinants. So we actually looked at almost 50 determinants, genetic of the mother, lifestyle factors, including sleep, diet, physical activity, also information on the maternal mental health, perceived stress and depression risk scales, and also some environmental factors, but not chemical in this paper, so smoking, and also more obstetric-related determinants, such as if the mother had preeclampsia or gynecologic factors. And we find, this is quite a dense figure, but we found actually some of the main determinants were the BMI of the mother at the beginning of pregnancy, was associated with most of the hormones, but also the age of the mother. So older women had a lower total testosterone and androgens metabolite. And this is the variance explained plot. So actually, we could explain with these determinants up to 10% of the variability in the hormone levels of these women. When we look at the actual determinants that were replicated across both cohorts, so we could find a higher BMI with a higher level of some of the corticosteroids, androgens, and also the number of children the mother had parity, physical activity, tobacco was it with the hormone health, age at assay, also the origin of the mothers, and the sex of the fetus. Then there were things we could only look in one cohort in BISC, but that's still 700 women. And we found also some genetic determinants, and very interestingly, maternal mental health at the time, cross-sectional analysis, were associated with some of the metabolites. Our second question was about how these early steroid signatures could be associated with child brain development. This study was done by Estelle, who is here and had a poster yesterday. In case you missed it, I'm going to explain some of it now. So with the same urine metabolic signatures, we looked at this association in both cohorts, INMA and BISC, on child neurodevelopment. We had longitudinal data. We had up to 6 time points in INMA, so from 15 months old children to 15-year-olds, so really covering neurodevelopment over 15 years. And we had different types of cognitive outcomes and behavioral problems. And we could replicate part of this analysis and assessment in BISC, but only looking at the early mental and psychomotor development because it's a younger cohort. And one of the main reproducible results was with this cortisol metabolite, which was associated with poorer early cognitive performance, and that was replicated in both cohorts. And another interesting result is that some of these effects were very sex-specific. So the hormonal exposure during pregnancy had different effects in male and female children. For example, androgen bioavailability, so we looked at ratios of the conjugate, was associated with more externalizing behavior in girls only. But some of the same metabolites, they were associated with better fluid intelligence in boys. So, and here I show the volcano plots, because I'm not going to go into every single metabolite, but you could see there is an overall tendency of effects, so red being females and blue being males, that there is a differential effect of this metabolite during pregnancy. Okay, so in the second part of the talk, I will go more into environmental determinants. And here we focus on a different outcome, but directly looking at the mothers. It's been underlooked actually in birth cohorts. We're always interested in the children, but I think it's a great opportunity to look at also midlife health outcome in the mothers. We have 20 years of follow-up of the children and somehow of the mothers. And one very important outcome to look at, I think, it's postpartum depression. It's very common, up to between 12 and 20% of prevalence across country. It occurs in the first 6 months after childbirth, but it can persist for years after if it's untreated. And 50% of cases are undiagnosed. And it's actually the main leading cause of maternal deaths in the first year. And it really matters. It has lasting effect on the mothers, but also on infant bonding and child development. And timely treatment can be very effective. There is a very easy way to treat postpartum depression. The etiology, there is a biological etiology from the withdrawal of hormonal exposure during pregnancy, and that's quite established. And the neuroactive hormones increase during pregnancy, and there is a sudden drop in postpartum, which affect the brain potentially in pathological way for some women. And also psychosocial stressors. Of course, severe life events, limited family support is a predictor, but not only. It doesn't explain all the cases. There is also clinical predictors, such as prior mental health issues, such as depression. There is a recent scoping review on environmental determinants, and there's been studies that looked at air pollution and postpartum depression, and they found some associations. Phthalates and PBDEs have been associated, and some emerging literature on PFAS and flame retardants that may have an impact. I'm going to talk about some potential mechanism, and metals. So, my background is biology, so I always like to look a little bit what could happen, what's our biological understanding of these associations. So for PFAS exposure, which we know is not one type of compound, there's thousands of different types of PFAS nowadays. So there might be slightly different mechanism for long half-life PFAS, long-chain PFAS, persistent ones, and the replacement one, the short chains. But it's been established that they cross the blood-brain barrier and may have an impact on the HPA axis, but also on basically neurotransmitter metabolism, so glutamate signaling, and also through neuroinflammation. And fourth mechanism, also PFAS may disrupt breastfeeding and oxytocin, which are important for mental health. And when we looked at effect of postpartum, there's different outcomes we can look at. We can look at the prevalence of postpartum symptoms, so it could be that depression starts already in pregnancy and lasts throughout to postpartum, or new incident cases in postpartum. And nowadays it's screened through this Enderburg scale. Actually, it's routinely implemented, at least in Spain. From the first visit at the gynecologist, they screen for postpartum depression with this questionnaire. So it's available very easily. And it has different subscales from anhedonia, anxiety, or depression. So in this study, there was actually a collaboration between Gary Joseph and Lauren Petrick in Mount Sinai, where we worked in the Progress cohort based in Mexico City. And we also had a look at the same question in the BISC cohort in Barcelona. So the two populations, both had available PFAS exposure and postpartum depression. Longitudinal, they were repeatedly measured in pregnancy up to 2 years. And, but there were slight differences in the way PFAS was assessed. So in Progress cohort, there are data from untargeted mass spectrometry in 1 month postpartum. And 8 PFAS could be detected through untargeted mass spec, and these were the one we were using, so their relative intensity or abundance. In BISC, we had targeted PFAS, and we selected the same 8 PFAS that we could be measured also in the Progress cohort. And we used the same model in both cohorts statistically to look at the question of how PFAS is associated with postpartum depression. What we found in the Progress cohort is that this PFAS, the PFNA, was associated with higher incident postpartum depression, so new cases of postpartum depression. And there was some mixture effect also of the PFAS on one aspect of postpartum depression, which is anhedonia. So, yeah. We can see the effect here. And you can see there is a specific effect on this subscale. Okay, what did we find in BISC? Nothing. There was no effect of these 8 PFAS that were also measured in Progress on the BISC mothers. Why did we see this inconsistent results? There could be many reasons. The two cohorts actually, they about, I think, 10 to 15 years apart in time. So potentially different PFAS profile. The timing of the exposure is slightly different, although these PFAS are persistent. So in Progress, they were measured 1 month postpartum, but in BISC, it was in the 3rd trimester of pregnancy. And slightly lower prevalence of postpartum depression in BISC. In BISC, the mothers, they're highly educated, higher socioeconomic level, potentially less socioeconomic stress. So that could explain also some of these differences. In our 4th study that's not published, I'm still going through the results, so I'm very happy here if you have any comments or suggestions. I thought, okay, let's take this very well-characterized cohort of BISC. Let's look at the Exposome approach, looking how together all the data we have in this cohort from psychosocial factors, which are very important for depression, socio-demographic, clinical factors, lifestyle, environmental chemicals. We have up to 50 different chemicals that were targeted in the urine and blood samples, and also including the hormone profile we have in the same population. So looking at all these potential exposome variables, covering different domains of exposome, how does this predict postpartum depression? For this, I had a student from more engineering who liked fancy, not so fancy anymore, but 2 years ago it was fancy, some machine learning prediction models. We tested different types of machine learning classifiers. And we picked the one that had the best performance based on the ROC curve. So we focused on the XGBoost model. and did some interpretation with SHAP values. So it wasn't just a black box of prediction. We could go back of what are the main predictors of postpartum depression in this model and potential interaction of the determinants. So what did we find? We find a modest prediction. So with all these exposome factors together, we had a ROC curve of 0.64. So not relevant for clinical diagnostic. For clinical diagnostic, you just need a questionnaire with 10 questions that would help you to predict it. But for public health, potentially interesting. So here we classified the different predictors based on their family. So we can see the main prediction came from lifestyle variables, then previous mental health determinants, but also hormones, contaminants. But when we look at individual variables, we see that after previous depression, the main predictor is one of the PFAS, and in the right direction, expected direction, because often these PFAS with brain outcomes, they can be protective or because of residual confounding or everything we talked about today. But here it was a more higher level of this PFAS, higher incidence of higher risk of postpartum depression. I was a bit worried when I saw that, because in our previous paper we saw that PFAS had no effect on the postpartum depression. But then I realized that this PFAS was not included in the previous paper. It's a new PFAS that we could only measure in the newer cohort in BISC. It's a replacement PFAS, a short chain, the PFBS. And so I asked Estelle to run again the analysis, including this other PFAS that we didn't include in the previous paper. And we found that only this PFAS here is associated with postpartum depression. Adjusting with using a DAG and more causal epidemiological framework, adjusting for the potential confounders, including breastfeeding, which is important for PFAS excretion, etc. Where does this PFAS come from? Why do we see this PFAS in particular? When we look at the concentration of PFAS in this population, because we have targeted quantified data, we see that it's one of the most abundant PFAS in mother's blood, with also PFOS. And there was also another study where they measured PFAS in tap water in Barcelona. In a subsample of the BISC mother, they measured PFAS in the blood and matching samples of unfiltered tap water. And they found that this PFBS is the most abundant PFAS in Barcelona tap water. It's not the main source of exposure, because when we correlate the blood level and the tap water level, they don't correlate. And in Barcelona, at least, we don't drink the tap water. We filter it or drink bottled water, but there could be other sources of exposure than just directly drinking water. So I don't know the main source. For the older PFAS, it's in our population, it was fish exposure. But this shorter chain, short half-life PFAS might be other sources. So I'll finish here with some take-home messages. In terms of looking at biological markers of brain remodeling and hormonal changes, I really encourage people to look at urine sample. I know Dinesh is very into the blood exposome as the main equivalent to genetic, but personally I'm a big fan of urine, because that's where most of the pollutant that goes through our body will be found in higher concentration, easier to measure. But also for endogenous metabolism, to look at microbial metabolism, it's a great sample. And non-invasive, much easier to collect. But you need maybe slightly more samples. The second thing is that steroids are very good biomarkers to track maternal and possibly offspring brain health, in particular some of the conjugated metabolites. And the third point is that replacement chemicals might be more associated with some brain health, neurotoxicity than the old ones. It's not because they have such a short half-life that they're not neurotoxic. Just makes them more challenging to measure. And also I want to emphasize that pregnancy and postpartum are under-recognized window of maternal brain susceptibility to chemicals, and very interesting life course period to look at. I would like to thank the cohort participating families, as we've seen in the trials. Also, the cohort participants, they have a very heavy protocol to follow. In BISC, they had to collect 14 urines during a week and many other things. So that's why we're always biased to more educated families. And I think maybe we can learn from these clinical trials on how to better recruit families that are not so well educated or higher social income. And the team also, I put this picture where I just had my second baby, and I'm using this opportunity to really connect with the families of Barcelona through the postpartum groups. And here's one example where we talked a little bit about our perceived environmental risk. What can we do about avoiding some chemical exposures for us, for the children? And that's it. Yeah.
Ashley Jaberge, University of Washington. Thank you for a really interesting talk. I had a question about one of the things you had posed as a limitation towards the end, which is the recruitment of people from lower socioeconomic statuses. And I was wondering, what's the current method that was used for the initial recruitment in the cohorts you mentioned? And is the method of recruitment potentially a cause of the bias towards higher socioeconomic status, or is it really, like what you mentioned, the burden of the multiple specimen collections?
So in Spain, and because of free healthcare, actually most women go to the public hospital. So the recruitment, it was through the first hospital visits. So here you reach most of the population. So I think it's more the burden. And also, yeah, I like the ideas earlier, like the lack of conception, like of prevention, and the conception maybe that women can't do anything about the environmental exposures. But yeah, the recruitment, I think it's, yeah.
Then maybe one quick follow-up question for the burden. Was all of the urine done through like a home collection and then mailed in, or was there any like in-person component that was required?
We're sending a kit to collect the urine at home, and then field workers were going to the house to collect the urine 2 or 3 times during pregnancy. But then there was also visits at the hospitals for anthropometric measurements, etc.
Yeah, I only asked because in some of our studies with good representation and lower socioeconomic status, they mentioned that having the flexibility to do the sample collection at home and then also like mailing it in was helpful, not having to coordinate times for pickups and things like that, because they have often very complex work schedules and also caregiver schedules. So maybe something to consider. But thank you so much for the inspiring work.
Hi, thanks, Léa. Very nice presentation. So knowing that you have MRI data in the BIS cohort, I think it would be great to also include this information, because like for depression in general, you can also determine some subtypes using MRI information. And I think this can add also some information regarding more the mechanistic and biological part. And actually, I also have another question more related to the machine learning model that you were showing. If I understood correctly, you have this Mexican cohort that is pretty similar to yours. So are you perhaps thinking to validate the model on that cohort?
Well, let's speak after the talk with Megan or anyone from Progress cohort interested in this question.
Could you repeat the question? I'm sorry.
Didn't hear.
In terms of the validation replication, I believe we have the data to do that, and I'll let Megan talk about the MRI.
It was a great talk, Leah. And yes, we do have, I think, very similar both exposure metrics in terms of a lot of the measures in urine, and I think we both followed very similar protocols for the MRI. So there's a lot of replication that we could do across cohorts, and also with the SHAP models. So with the XG boost and the exposures, as well as with the MRI. So it's a good point. Very good.
Yeah, just to specify, we don't have brain MRI in mothers in BISC yet.
Same answer for progress. Yet.
It's just a technical question on the distribution of the metabolites you have. What we see in our data is sometimes very, because of the detection thresholds, so there is not much into the data. It's not Gaussian variables, but really very few people have, in fact, detected metabolites versus a lot of missing data. So in practice, how do you deal with that kind of data? It's sometimes very challenging to integrate all that. Do you have a strategy to share with us, or a common pipeline, or is it case by case and you, depending on the database you are treating?
Yeah. So actually, if I have 1 minute, in this project we did only targeted profiling. So hormones were targeted, all the chemicals were targeted. So we don't have so much this issue because we have a low limit of detection and very robust measurements. Because here we had strong hypothesis-driven work. But now we're going back to exploratory work through the athlete project and the BISC model. We also have untargeted, where we have this issue of a lot of missing data, and you need to use several approaches, keeping all your data with low missing threshold.
And sometimes you have to binarize your data, and then the models become very sensitive to that mixture of data, which are continuous versus binary. And it's a technical question. We can discuss that.
No, if it's exploratory, you need to have a lot of samples to have enough detection. And if you have a strong biological question, then you shouldn't look at untargeted data. You should look at targeted assays. That's